Eğer ki hayatımızda hiç eğer olmasaydı nasıl olurdu? Size şöyle söyleyeyim. Her şey daha az parlak, daha az yeşil olurdu ve daha az parlak yeşil. Çünkü eğerler ormanların derinliklerinde tek bir kibritle derinlerin kıvılcımını ateşler. Eğerler Nobel ve Guggenheim'ın aklına takılır ve o kodu bu kodu çözerler. Eğerlerle içinizden haykırmak gelir. Eğerler bariyerleri kırarlar. Asla yalnız yürümezler ve aşırı bulaşıcıdırlar. Eğerler aşikardır ve son anda golü atarlar. Eğerler dünü umursamazlar. Robotlarla bile konuşabilirler. Karşı takım soluklanırken oynamaya durmadan devam ederler. Sadece basit bir kelime öyle mi? Hayır. Eğerler asla uyumazlar. Hep daha fazla çaba gösterirler. Eğerler bakar, araştırır ve en beklenmedik zamanda ortaya çıkarlar. Eğerler klonlanarak çoğalırlar. Acaba gerçekten yapabilir misin? Yaptım bile. Eğerler aklınıza girmeye çalışan güler yüzlü şakacılardır. Eğerler kapıları açarlar. Asla kaybetmeyeceklerini bilirler. Ve biraz gün ışığına her zaman hazırdır. Her şey bir eğerle başlar. Çünkü eğerler ne zaman dönüşür, ne zamanlarsa şimdi. Ve şimdi nasıla dönüşür. Nasılsa asıl. Eğerler bakış açınızı değiştirir. Eğerler oyunu değiştirir. Eğerler dünyayı değiştirir. Biliyoruz. Çünkü biz eğerlerle çalışıyoruz. Yakın Doğu Üniversitesi.
Kuzey Kıbrıs Diş Hekimleri Öğrencileri Birliği'nin düzenlemiş olduğu DENTALKS etkinliğine hepiniz hoş geldiniz. Ben Lefkarka Üniversitesi 3. sınıf diş hekimliği öğrencisi ve bu yılki ENKETS Bilimsel İşler sorumlusu Nursema Gür. Sizlerle tekrar bir arada olmak çok güzel. Bugünkü konuşmamızda Doktor Behnam Shakibaie bizlerle birlikte olacak. Daha fazla uzatmadan sözü sevgili Bilimsel İşler Delegesi Sabah'a bırakıyorum. Sabah, we can't hear you.
Greeting everyone. I'm Saba Mahmoudi, member of NCATS community. Are so honored to have this privilege of having Dr. Behnam Shakibaie at our presence. We are so enthusiastic about this webinar taking place right now. Dr. Behnam Shakibaie is a pioneer of implant microsurgery. He has developed new microsurgical techniques and instruments for oral implantology and jawbone reconstruction. Dr. Shakibaie heads the implant division of microdentistry community, Macrovision. He graduated from Berlin University and gained a passion for oral surgery during his doctoral thesis at its surgery department. He specialized in oral surgery at Berlin University and earned mastership in implantology at DGI in Germany, mastership in periodontology of DGP in Germany, and specialization in oral microsurgery and microdentistry of Zeiss Dental Academy in Switzerland. Moreover, he has scientific collaboration with University of Michigan and University of Pennsylvania since 2018. Now, I would like to invite Dr. Shakibaie to bless us with his knowledge.
Hello to everyone. Thank you very much, dear Saba, for the nice introduction. And thank you for arranging and managing everything to become true and for the invitation from NCADS, your association in Cyprus. I am very happy and proud to be able to share my experience from last decades with you tonight. Okay, before going to the main subject, I want to show you a short video. Let's go. As every one of us knows, dentistry is progressing very, very fast. We are spending a lot of money, our lifetime, to implement new technologies and new treatment protocols into our daily practice. Without advanced tools and sophisticated methods, no one is able anymore to provide a state-of-the-art dentistry to his patients. And it has become very hard to keep the speed of this progress. The question is, why are we taking so much efforts and spending that amount of money and time for our patients? This is the main question. And the answer is, we want to increase the precision as much as we can in order to be minimally invasive. And then that brings me to the main topic of today's lecture, which is minimally invasive concepts in oral implantology using the operating microscope. On this picture, you see me in almost your age. I was 21 years old, and at Berlin University in 1993, in the first semester, I had a lot of dreams, but I never dreamed of to become the professional I am today. But about this, I will tell you later a little bit more. 26 years later, you see Behnam at the EAED meeting in Munich, 2019, shortly before the outbreak of COVID-19, as invited guest. And you know, EAED is crème de la crème of dentistry in the world. It was a very, very long story of hard work and sacrificing work to become one of the influential figures, at least in implant microsurgery worldwide. The key to this success, I will try to visualize for you during the next 60 minutes, and will sum up with some key recommendations for you because you are at the beginning of your career. So I knew at the day as I graduated from dentistry that I have to specialize much more in dentistry, in different disciplines of dentistry, as much as I can. And I cannot end up with general dentistry. And very soon I realized that I have also to spend as much as I can for new tools, because specializations are not possible without the appropriate tools that you need to provide the specialization to your patient. And few years after my first specialization, I realized that only oral surgery is not enough for me to treat my patients multidisciplinary. And the key success is to get the patient treated in your clinic in all aspects of dentistry. Either you make a teamwork or you specialize yourself in different fields of dentistry to cover this kind of multidisciplinary treatment plan yourself. And then, of course, you need the specialist knowledge and skills in all the fields that I mentioned if you do it alone and yourself. Also, if you do it in a small teamwork, it's very, very recommendable that you have full coverage of all the other specialists in your team, and you understand what they are doing with your patient every day. According to this plan, or to these important issues, I tried to set the steps of my career. 1999, I graduated from Berlin University, as you heard before. 2003, specialization in oral surgery at Berlin and Bonn University. 2006, mastership implantology at DGI. This is the German Society of Implantology, or German Association of Implantology. Then 2 years mastership of periodontology. Each of these masterships, they take 2 years. At DGP, this is the German Society of Periodontology. Then 2 years a specialist program of microdentistry at Zeiss Dental Academy. And from 2006, publishing, lecturing in microsurgical implant techniques internationally. 2013, international instructor of Zeiss Dental Academy, which I am still today. And from 2018, we started the scientific collaboration with Pennsylvania University and Michigan University. Michigan is right now, according to Shanghai ranking of all the dental schools, is ranked #1 in dentistry, and Pennsylvania is ranked #5. So 2 of the world leading universities in the world. About this collaboration, I will tell you a little bit more later on. The topic that I have today to discuss with you is a topic that I have been researching and publishing in since over 12 years. So if you are interested to read some of my articles, and new articles are coming up in the next years, I will give you all the links to get more data and more details. If you look at the PubMed, we very soon realize that the future of dentistry belongs to minimally invasive treatment protocols. You see a clear tendency of increasing number of publications, no matter in which discipline of dentistry. When we are talking about minimally invasive implantology, of course, we have some basics to understand that are very important to realize this concept of treatment in implantology. First of all, is minimally invasive tooth extraction. We have to think about our treatment strategy of each tooth long before we take the tooth out. And then socket and ridge preservation as atrophy preserving techniques, of course, implant microsurgery itself, and 3D analysis. And when we are talking about implant microsurgery, we need certain conditions to be able to realize that and to provide it to our patients on daily basis. So it's very important to understand that using microsurgery or doing microsurgery needs much more time than we have in conventional implant treatment. Of course, we need special skills that can be trained in different courses or different masterships. Optical magnification is absolutely necessary, like micro instruments. The clinical concept of the dentist has been reviewed totally. Assistants must be trained itself, and of course, like all the other treatment concepts, we need more and more experience to become successful in this kind of treatment. Let's have a look in our surgery room when we are preparing an operation on sinus called microscopic sinus lifting. This is my most famous technique that I have developed during the last 12 years. I also have developed the instruments for this sophisticated technique. We have to prepare the room like for all the sterile operation techniques and operating microscopes. Operating microscope must be is a must in this operation. The sitting position of myself, of my assistant, and the assistant who is my assistant who is recording the videos is in certain position. You will see the videos and the pictures that are very, very nice and very, very highly adjusted in position later on. Today's microscopes have advanced characteristics that enables the surgeon to provide the operation in totally sterile environment while he is sitting behind the tool in absolutely convenient ergonomic position. And that's very important for the doctor to provide and to give the patient the best possible quality treatment. Of course, the ergonomics are very important in our daily life, not only in dentistry work, in our daily life. And by looking at these two pictures, you can understand why we are talking about better ergonomics when we are using the operating microscope. It is also very important to understand that working behind the microscope needs certain skills and patience, experience to get out best possible results in this working position behind the microscope. I recommend all my students in different mastership programs or fellowship programs around the world to first start with loops, and in second stage go over to using the microscope in order to get it a little bit easier to handle the sitting position. As we have limited time, unfortunately, I cannot spend that much on every slide. I just want to scratch the surface for you and give you some impressions from my daily work, because I work with the microscope all the time. We have a multidisciplinary microscopic dentistry clinic in Tehran, where I take only 5 patients per day. This is, I think, the only one dental clinic in the world to have 5 patients per year. And we cover all the treatments, all the dental treatments of this 5 patients with microscopic procedures, beginning from restorative, prosto, endo, augmentative procedures, implant dentistry, and this way you can better understand that I keep educating myself all the time. And that's very important if you want to succeed on the highest level on dentistry, and provide the best possible quality to your patients. Okay, come back to this slide. Indications for using the microscope are numerous. I have published these indications in different articles in the past. You can read about it much more. I have picked some of them for you to visualize the clinical situation of them for you a little bit better, using pictures and videographies. First of them, or to talk about first of them, we go to minimally invasive tooth extraction, socket preservation, implant placement, and prosto in one particular case. Okay, first, just a moment. Okay, just to get into the subject, I will show you a short video that shows you how we extract a hopeless tooth and implement the socket preservation technique. The tooth number 1-4, you see here, we have unfortunately deep caries and via falsa. All the instruments you see in our videos, most of them are microscopic instruments. They are especially designed to be used under microscope working circumstances. So we dissect marginal fibers, and we make a division of the root. As you know, if the aim is to extract the tooth minimally invasively, you have to divide it in some parts. First, we take out the vestibular part, then the palatal part, or the rest of the two roots. Then we go in and check the situation of the bone or the bony socket. And the most important part of this socket is the vestibular wall, as you know from implant guidelines. Okay, this is the clinical situation after cleaning the socket. Then we augment the inside of the socket with BioOS large sized granules, and we compact the augmented socket, cover it with gelatin sponge. The gelatin sponge has the function to rebuild or to help rebuild the gingiva with higher speed or faster, and secondly, to keep the bone augmentation material in place. Okay, a crossing suture finishes the operation. 3 months later, before the implant insertion, actually, this is a technique I have published several times, and this technique was also the reason for me to receive the first German Periodontology Award in 2010. After 3 months, you see the very good healing situation, and this technique has preserved the three-dimensional form of the ridge of the alveolar ridge. In almost 90%, we lose only less than 10%. Compared to doing nothing, you win a lot of volume, a lot of bone, and fixed gingival volume. Okay, this is the bone height, and the 3D situation is very, very satisfying. Okay, clinical case. That case is a part of our new article that is already accepted by IGPRD and will published I think at the end of the year in Chicago. We have three teeth next to each other. Number 2, number 3 is missing, as you see here. Number 2, number 4, and number 5. Okay. Of course, we need deep prosthetic plan, and according to the prosthetic plan, we know that we have to increase the width to a better lip support in this area. The patient is unfortunately rejecting any kind of orthodontic treatment, and also the possibilities for orthodontic treatment is also limited because all the teeth are damaged more or less. Okay, we start this patient, and I told you before, we integrated this case into our study where we are comparing for the first time in the world. We are comparing in a prospective clinical study in direct comparison, the two most selling augmentation materials in the world, which is Bios and Cerabone from Botis. Okay. This is the result of minimally invasive tooth extraction. Sorry, I go back again. Minimally invasive tooth extraction means we only move the teeth or the roots in vertical direction, and we are only allowed to make some rotation movements, no horizontal movements of the teeth. This is very important to give up any horizontal motions. This is the result of the minimally invasive tooth extraction. As you see here, we have absolutely healthy sockets, and most importantly, healthy vestibular or buccal plates, and also a healthy gum situation. So we made all the measurements for our study according to the defined guidelines for the prospective trials. For you to understand, important to understand is that we filled in this particular case the middle socket with Bios, left and right side were filled with Cerabone of Botis. Okay, the procedure is always the same. The operator or the surgeon was always myself. Progress of we proceed the surgery with covering the socket entries with gelatin sponge, as I showed you before in the video. All the materials, all the gelatin sponges were from the same company. Okay, then we made the crossing suture and measured again all the parameters and followed up the patients over 4 months. And look here, this is very important to see, are very interesting. all these sequences were filmed or were documented with the microscope. You have the same kind of illumination. You have same kind of adjustments of filming and photography. It's it's a unbelievable tool for, especially for research projects, if you are interested in. So look at the situation here. The middle socket after 10 days is wide open, and left and right side are going to close faster, we think. If we check the situation after 1 month, the healing process is in the middle socket with BIOS is getting much faster than left and right with Cerebone. After 2 months, we have a total closure of the fixed mucosa in crestal region in the middle socket. Compared to this, left and right are still open. After 3 months, we have a still closure here, very good situation. Left and right is still open. After 5 months, the sockets of Cerebone are able to close, and this is, this is too long, because if we go with BIOS, the biocompatibility for this special technique, let me say, seems to be better, and the tissue, the soft tissue is healing much faster, much better. Once you have the closure over the crest, 2 weeks after this time, you can start setting or operating the implants. If you start earlier, the bone or the bone substitute material on the surface is still not integrated, and you will remove it with by opening the flap. Okay. Vertical dimension is comparable, better situation in the middle socket than left and right. Okay, then we start to plan the surgery and measure all the parameters three-dimensionally, and plan the surgery with a 3D operation guide. Okay, but in this stage of preparation, we realize that the bony dimension of the ridge is comparable. There are no big differences in the both different sites, at least in the radiography. Okay, then we go into the operation or implantation surgery itself, and you see it's it's necessary to split the tissue on the surface in the crestal area in order not to remove the periosteum from the surface. This is very important for the success of this particular operation, because if you open a full flap, most of the time 2 or 3 millimeters of the surface augmentation material or bone substitute material is still sticking beneath of the periosteum, and if you open once you open the full flap and raise the periosteum, you raise also, or you lose 2 or 3 millimeters of the bone height. That's very important point if you are interested to implement this particular technique into your practice. This is the most important picture in the study, where we see, where we see the clinical situation of the crest. In the middle site with BIOS is hard bone, totally mineralized, and very suitable and ripe for implantation. While you see the situation here, we have still ongoing granulation process here and here, minimum up to a depth of 3 to 4 millimeters, which makes the implant surgery itself more challenging. So as mentioned before, we prepare the guide, a 3D guide. We know exactly in which position, with which angle, and what parameters of the implant we are going to make the surgery. Also the depth of the implants were measured before according to the future prosthetic solution. So we inserted 3 bone level Straumann implants, 3.3 and 12-meter height. Okay, this is the clinical situation after the implant insertion, and 6 weeks later is time to open the sides and make a split rolling flap. About this technique, I will tell you also later on a little bit more. This is a very precise and well-promising technique that I can really recommend to everyone to learn it, because that will increase the quality of your implant treatment significantly. Please note that in all implant exposure areas, we spend a lot of time, I paid high level of attention to keep the future papilla structures, okay, or to preserve the papilla structures. Okay, we go on. 1 month later is the situation very nice, and we have a very good forming or form of alveolar ridge exactly in the extension line of neighboring teeth. Then we go into the prosthetic treatment, giving the patient 3 single units of full zirconia, individual zirconia abutments, individually milled zirconia abutments with zirconia crowns. They were bonded extraorally and delivered to the patient. As I told you before, we have planned to give the patient a little bit more lip support, because she had a collapse of the left side of the lip, and she desired, or she wished to have a little bit lip filling in this area, and so that was the reason why we decided to make the dimension of the crowns a little bit bigger than the dimension on this side. Of course, there is room for discussion for the anatomy of each tooth, and we are trying to improve the prosthetic treatment. This case is already 4 years old, and we are trying to improve the anatomy and colors from month to month. And also from the side, the view from the side is really life-changing. Okay, open sinus lift is one of my big favorites in implant microsurgery. We have designed the special instruments already 12 years ago with Zepf Dental in Germany. This is actually the only one microsurgical open sinus lift instrument set in the world. It's still the only one. There are some copy from that in China and in India, Pakistan, but still the original one is manufactured by Zepf Dental in Tuttlingen. Now let's have a look how you can use this kind of instruments for very, very hard and tough sinus lift cases like this. You see, we have almost nothing in the sinus ground. Somehow here's less than 1 millimeter bone height remaining, and we have here arteria in the vestibular wall. If you open this arteria, you will have a crazy bleeding during the surgery, and that will somehow stops you from continuing the operation. And if you don't give this patient open sinus lift, you will not be able to treat the patient with a long-lasting prosthetic treatment. So that's very sensitive treatment, and it needs very, very precise planning, time consuming. You need to check all the aspects of the sinus itself, also of the bony structures. Fortunately, the mandibula was resorbed or atrophied, but only in posterior area. We had the chance to use the intraforaminal area, but in maxilla, when I go back, that is the biggest crazy case I had in my career in the last 15 years. Okay, then, as I mentioned you before, every case is analyzed and treated by a very precise guide. It is not easy to treat edentulous patients with such a high amount of atrophy with a guide. If you even go with fixed guides, there is only a spongy bone. You are almost not able to fix even your 3D guide in the paranasal area. So, let me tell you, it's super crazy, okay? Our original plan was to go with 8 implants, 4 on the left and 4 on the right side, and to augment the ridge accordingly. What does it mean? It means we had we augmented the ridge in this area with 2 blocks from retromandibular region and 2 blocks in this area. Okay. The problem of this particular patient was that was the point that she was, or her maxilla, at least her mandibula was much better, but the maxilla was melting the augmentation material, or the autogenous bone blocks like butter in the sun. I never saw such a case before. I don't know what the reason was. We had no pressure on the tegument like using prosthesis. She was not using. I told her, or we took her total dentures away. She had no denture. She was wearing a mask. So I cannot, explain or understand how it came. But that was the case. So we had to use the bony material she provided, or she had still remaining on the ridge. So we positioned 2 implants here. Of course, it's, compromised on the palatal aspect, but on the vestibular aspect, that was very good. please keep in mind all these operations are done on the microscope. Without the microscope, I would be never able to have such a look and such control on each step. Now I will show you, I will first show you the open sinus lift on the left side, okay? This is, I will stop at some points of the video, okay. Before we start to make the osteotomy or to prepare the hole or the window, better to say the window, we have to make an exact analysis where this window has to be on the vestibular area. Okay, if the window is too high, it will become problematic for you to go into to enter the sinus, elevate the membrane, and go into the sinus ground to elevate the membrane from the bottom on the sinus in all areas of the sinus ground. So too high, setting the window too high on in the area of crista zygomatico-alveolaris is not helpful. If you take the window too low and you come down to the crestal area, you will have the problem of resorption, and you go on risk to put more resorption on your ridge, because the ridge is, you saw the pictures before, is itself very, very weak in the material, and after opening a full flap, you will have 1 to 2 millimeters of atrophy. So you have to balance the position of the window, not too high and not too low. Normally, if you set the lower line of the circle 4 to 5 millimeters away from the ridge, and 2 millimeters minimum, 2 millimeters higher than sinus ground, you will have the optimal 3D position of the sinus window. Okay, so then you start the preparation with a bore of diameter 1.2, not bigger, because the diameter of your window is 4 millimeters, only 4 millimeters, super small. So you see here, once you have the first superiostal vessels of the sinus visible in the microscope, you become very careful with the osteotomy, and even you stop the osteotomy. Normally, once you see the vessels here, the superiostal vessels, you have removed enough bone layer to be able to break the rest or remaining bone layer towards the sinus. Okay, you see the vessels are bleeding, so I stop here. At this stage, I stop the preparation, and then I start breaking this very small remaining bone layer with the sinus lift, the micro sinus lift instrument number 1. We have 9 different instruments for all the areas of the sinus, from mesial, distal, ground, and cranial. Okay, so you go, I mean, I don't want to go in the details with this video, but we provide special courses in cooperation with Zeiss Dental Academy, especially on this subject, to train the colleagues and the dentists in theory and in practice in detail how they can provide this technique very securely on daily basis. Okay, so you see the window is only 4 millimeters of diameter. You can imagine is very, very small. Then we start augmenting. You see the breeze synchronic movement of the sinus membrane, which indicates that we have no injury in the membrane. So that is very important to understand this stage. We first augment the medial part or the nasal part of the subantral space, because if we put the implant and start then to augment, we cannot, we have no access behind the implant. Okay, so before setting the implant, we augment the medial part of the subantral space. Then we set the implant and start to augment the rest. Rest means distal, mesial, vestibular, and caudal and cranial area. Okay. In order to place the particles in each corner of the subantral space, you can use the instrument of the set, because they have the best access. And then we cover, of course, even this small window with a membrane. Okay, we finish the operation with the wound closure. You remember we set some implants in this area and some implants in this area with a very, very small external bony window. Now on this picture you see a very useful trick. When you have a big sized flap, in most of cases, when I see colleagues suturing the flap, they start from mesial and go to distal, or they come from distal and go to mesial, okay, or they start here somewhere and go to mesial and distal. I recommend to, in all my lectures and practical courses, to use some corresponding sutures that bring key points of the flap together with corresponding points of the palatal mucosa. Okay, once you have defined the corresponding points and your flap is fixed in position, you can set the accessoric sutures, and you can be sure that there is no displacement of the flap, and you will certainly achieve the best healing result after 1 week. Okay, so now I thought myself, when I operate the right sinus, the left sinus, left and right sinuses bilaterally, they were looking like each other. We had only 1 to 2 millimeters remaining, and the situation inside of the sinus was healthy. She had no pathology inside of the sinus. Okay, so I thought myself, right side was, let me say, easy. Left side will become also easy. Okay, and we started the operation with the same planning and same acting. Okay, but look what will happen here, unfortunately. So we start again here, and we have the small access, but look what has happened here. Did you see? Tak. Oh, sorry. Sorry. We go back to the video. My God. Something is wrong here. Something is wrong. Okay. I think you can see the perforation right here. Yeah. You can imagine I have operated this technique more than maybe 300 times within last 12 years. But sometimes I have no feeling, I have no sensitivity in my fingers when a perforation occurs, okay? And this is one of the cases I had no idea how it could happen, because I'm working with very limited amount of pressure and very carefully, but sometimes you have such a situation. Okay, once you have a perforation, unfortunately the operation becomes more traumatic. That means you cannot continue with a small hole of 4 millimeters. You have to visualize the dimensions of the perforation. So this way you are forced to make the osteotomy bigger. Okay, you see I have here maybe 3 times bigger size of the planned window, but I was forced to do this, okay, because of the perforation, of the accidental perforation. Yeah. No, I taught myself, because according to my experience from last 10 years, I have managed numbers of I taught myself I make the extension of osteotomy, and I will prepare or release the membrane, prepare the membrane around the perforation, release the pressure, and the size of perforation will smallize itself. But it unfortunately it didn't work. Yeah, you see here. So now, oh my God, sorry for that. I don't know why I'm jumping to the next slide when I try to stop. So look at this. We have bony island. We have a bony island here, okay? And unfortunately, the membrane is sticking to this damen bony island. The bony island has very sharp edges. I wanted to keep the bony island first, yeah? First, I wanted to keep it and to bring it or elevate it together with the membrane towards the lumen of the sinus. But it was moving with each breathing, and sorry. It was moving with each breathing movement and was making the hole bigger and bigger, okay? And you can imagine I was sweating on my back all the time. This operation took me almost 3 hours, and it was such a high stress because I was thinking, if I don't do somehow the open sinus lift for this patient, my whole therapy plan will go down the mountain, you know. So it was very hard to remove this bony island, and without microscope or a microscopic or microsurgical pans like this one I am using here, I could never remove this bony island, and it would rupture the whole membrane after a while. Yeah, look, this is the lucky moment. Yeah. So thank God I removed this sharp-edged bone piece, and then I could stick. So I used the membrane to seal or to stick the perforation, and then we moved on with the augmentation. I just wanted to clarify with this video that the microsinus lift itself can become also very, very stressful sometimes. But if you compare it with the conventional technique, where you remove almost the half the half of the half amount or half area of crista zygomatico alveolaris, it is much less traumatic for the patient, and also the healing process is much better because you preserve a lot of bone, which gives your augmentation area or your augmented area the important or the necessary stability to integrate into bone first, and secondly to supply the area with fresh blood. Okay, but that are characteristics of this new microsurgical sinus lift, open sinus lift technique that I don't want to describe much more. As I told you at the beginning, I just want to scratch the surface for you and to give you idea and make this subject for you much more motivating to think about learning microscopic techniques in implantology or in general in dentistry. So I told you before that it was a very hard case. So in this area, unfortunately, we lost 2 implants. In the frontal area, we made the Khoury technique with autologous bone plates and set 2 implants. Here I added 1 implant more because I lost 2 implants here, and this clinical situation moved us to choose a bar construction for the patient. You see the simulation of the bar here. That was milled 3-dimensionally, and it was setting passively without any pressure, without rocking. It was fantastic sitting. After having the simulation here, we turned it into a bar with attachment, with golden attachment elements for the supraconstruction or for the prosthesis that you see here. This is the definitive situation with changeable attachments in the upper and lower jaw. And you know, this patient, you can believe me, I operated this patient almost 1.5 years. I don't know how many hours, maybe 80 hours in 1.5 years, and I was so happy to close this case with such a result. And the patient was super happy. We changed her life, and I cannot describe the feelings of this patient after receiving the final prosthesis for you. I think you can understand when you saw the pictures here. Okay, my last subject that benefits from implant microsurgery, or the last indication that I selected for you today, is implant exposure. Implant exposure has become super important for the perspective, or for the prediction of success of prosthetic treatment in the last 10 years, really increasingly. And we will have to spend a lot of attention on this subject in the future. So therefore, it has become one of the focus of our research together, our latest research together with Michigan and Pennsylvania University. And I will give you some ideas what we are right now researching on. Okay, this one is some parts of a clinical comparison study of a split rolling flap, VSRF, versus double door mucosal flap in direct comparison. Also, the first time in the world that these two techniques are compared in a clinical environment in direct comparison. Okay. Also, this article has been reviewed by IGED, and we have revised the article and are submitting the article next week again to IGED. I think it will be published at the end of this year, or maybe beginning next year. We had 10 patients, 44 implants, as the implants were divided in two groups. 22 were in VSRF group, and DDMF group, which is double door mucosal flap. There are also 22 implants in the second group. Okay. So you see the structure of this study. We have patients receiving implants where the implants were submerged, and the study started at the point when we were reopening the implants and designing the form of the mucosa on the vestibular aspect. Okay. Then we control the patients in a fixed protocol according to check the healing process on the vestibular aspect. All the patients received here. All the patients received a temporary treatment with 3D milled metal abutments, and also 3D milled crowns, zirconia crowns, wearing them for 6 months. And after 6 months, they received full zirconia abutments with layered porcelain. Okay, but now I will show you the details of this new split rolling flap technique. I mean, the split rolling flap technique itself is not new. The idea has been published in last 2 decades, several times, but there is no direct comparison which shows that using this technique is beneficial compared to the conventional technique where we just make ordinary incision in the middle of the crest and open on the vestibular and on the oral side. This the results of this current study will, I think, revolutionize the idea of a split rolling flap and motivate the colleagues worldwide to learn or to implement it into their therapy, into their implant therapies. Okay, in this particular case, we decided to make the split rolling flap here in this area, and in this area, just in the neighborhood, we applied double door technique. What does it mean? Designing the flap of split rolling means we have to extend. Just a moment, I will go back. So, can you see my mouse? Guys, can somebody answer me?
Yes.
Can you see the mouse
Yes,
here
we
on
can see
the
that.
left side?
Yes, we can see.
Okay, so I will just draw you the incision line. Yeah, okay. So the incision line goes like this here. Okay, it means we go over the midline of the crest. The midline is here. Yeah, we go over the midline, maybe 80% of the width of the crest. Okay, here, and of course the implant has to be in the middle of the flap and go here and go back here. Okay, so this is the outline of the incision when we talk about vestibular split rolling flap. Compared to this, or in contrast to the rolling flap, we apply the incision differently here. We just go with the double door technique. We just go in the middle of the crest. Okay, it means we divide the keratinized tissue in this area to a vestibular, to a same size, or to same size vestibular and this and oral part. Okay, and make somehow edge design. Okay, one incision here, one incision here, one in the middle. Before raising the split rolling flap, of course, we have to remove the epithelium in this area because we want to push this part into an envelope here. We prepare an envelope here in this area with a microblade, and we roll this and put it here into the prepared envelope. In contrast to this, here in this area where we have the edge incision design, there is no need to remove any epithelium because we don't roll anywhere. Okay, I was speaking about this technique with Markus Hürzler. I think you know the name, is the famous periodontist from Munich, and he's a good friend of mine, also Otto Zur. And I asked him, why don't you use this split rolling flap that you have published, I think 15 years ago? Why don't you use it anymore? And he told me, apparently there is no benefit in using this particular rolling flap compared to the conventional flap where we just make edge design like here. Apparently there is no difference, but it takes a lot of time. We have to deepitalize, we have to split, we have to roll, we have to make the envelope, and so on. So he is making it maybe very rarely, he told me, and there's no benefit. But after I showed him the results of this study, he was motivated to restart again, this technique. Okay, now you see the design in detail. We go over 80% of the ridge here and use this material to roll in here. Yeah, where we have here only the edge design. I mean, this is mobile mucosa in this area. Therefore, my incision is a little bit crooked here, but it should be like this. Okay, this is straight, this is correct, but this one should be also here. But because of movement of the mucosa, unfortunately, it is a little bit crooked, but it doesn't matter. You will see. So then we open a split flap, like raising the flaps before I showed you on the crest. We only split and keep the periosteum on the surface. Okay, that's crucial for the success of this technique, because without the periosteum on the surface here, we will lose the height of the bone, and your implant will grow out, will come out of the gingiva after a while, and that's not nice to see the metal edge after a while. Okay, good. So then we set the gingiva former, and you see here we have a small line here where I have prepared the envelope. Okay, here is the envelope. Only a small envelope, maybe 4 millimeters high. That's enough. In this envelope, we roll in. You see here. Okay, I will show you a detailed video right now, but those pictures are also very interesting. Compared to that, we just open here on the left and right side and change the screws. I mean, remove the cover screw and bring in the gingiva former. Okay, so that's after the operation. This situation here, please, it's very crucial to use microsurgical sutures. This is 6-0 10 size needle. Without 6-0 or 7-0, you will destroy the edges of these small flaps. So if you go for these techniques without microsurgery, you can forget it. And please note, also in this case, we preserve always the papillary structures. Okay. Now I will show you the video of the same patient that we have removed his tooth or hair tooth minimally invasively with socket preservation. Now you see the implant operation 4 months later with a split rolling flap. Okay, good. Let us check the vestibular part and then we start the video. Vestibular split rolling flap. You remember this situation? This is just a continuation of the last video. Preparing. You see the preparation is always in respect to papillary structures. Okay. When you are acting on the microscope, you don't need to open that much because you see much better. Because of your better view or your visual control, you don't need to open that much. And this way of protection of the gum will give you perfect prosthetic results afterwards. Okay, now we define, I told you before, we go over 80% of the ridge. Yeah, we pass the line, the middle line, we go to the palatal aspect and borrow the tissue from the palatal aspect. Before raising the flap, we need to remove the epithelium on the crestal part. Only on the crestal part. There is no need to take the epithelium on the vestibular aspect. Okay, so everything is controlled on the microscope. So not too much pressure here. Okay, if you push too much, you perforate the thin, sometimes very thin keratinized gingiva, keratinized mucosa layer. Okay, so then always check the thickness of the gingiva. You can only roll exactly and precisely when you know how thick the gingiva is. If it's too thick, I mean too thick means more than 2 millimeters, you have to open your envelope a little bit deeper. If your gingiva is thin, 1 to 2 millimeters, or maybe only 1 millimeter, after removing the epithelium, you don't need to open the envelope here very much. Okay, so then we need to use all the time micro elevators and micro suction. This suction has only 1 millimeter inner diameter, and now we have raised the flap. Okay, so look at this flap. This flap has a dimension, or has a dimension of 3 millimeters. Okay, 3 millimeters width. This is the length, this is the width. Do you know a holding instrument that can hold this very small 3 millimeter flap in place that you can give to your assistant to hold it? Maybe some wound holders from ophthalmology. Only there you can find such small holders, but unfortunately they are the angles of ophthalmology holders are not suitable to be used intraorally because of the chick. So I checked ophthalmology holders, but they are not usable. I can tell you this. So don't go for ophthalmology instruments to hold such small sized or micro flaps in place. Okay, you have only 2 ways to secure the flap on the vestibular aspect, as there is no at least right now there are no holders. Okay, even if you have holders, your assistant will not be able to hold it all the time because it is very slivery, like a fish. You try to hold it, it's away. It's just in a second. So there are only two ways to fix such a small flap on the vestibular aspect. First, you fix it with a small holding suture, as you see here. This is a 6-0 suture with 13 size needle. Okay, now just go back. Okay, this is a very nice picture where you can see the result of our socket preservation. You saw already the 3D radiography and the very nice dimension of the rebuild ridge. But now you see it clinically. But please keep in mind that there is always periosteum on the surface. Okay, no full flap. Very nice. Right now we move on with the implant placement according to the prosthetic plan that we implemented before. So, and now here the microscopes, the big help of the microscope at this stage of the operation is to visualize or to give us the possibility to check the depth of the implant. I have planned to be 1 to 2 millimeters beneath the crest. Okay, and here I check the sitting depth of the implant exactly 2 millimeters beneath the crest. Next step is to bring in the gingiva former and then to release the flap on the vestibular aspect. Oh, sorry. On the vestibular aspect again, this is very important to understand here. Okay. Now the gingiva former, of course, always brand new gingiva formers in this kind of operations. And now I roll it here. You see? Could you see the rolling movement? You hold. Please note, this is very important point. Another important point. We always use atraumatic round or circled pans, microsurgical pans. We don't use the conventional microsurgical pans with sharp tips, because by holding this small, this kind of small flap with the sharp edges of the micro pans, you will injure the flap, and after holding it 10 times, and you need to hold it several times, you will disappear very easily. So please keep in mind always atraumatic micro pans, very important. You hold here with one hand, and with the other hand you roll the flap into the previously prepared envelope in this area. Okay. One movement. If your envelope is deep enough and the size is suitable, it goes in like a fish. Then sutures, of course, they have to be on one line in order to avoid displacement of the flap on vestibular aspects. Okay, I will tell you what I mean with one line. Look at here. This note is here, and you make a line. The next note is also here. Don't put the note here or here or here. okay? And don't go into the flap here. Otherwise, you will have displacement and it will not sit at the shoulder of your implant so nicely, okay? We have already finished the prosthetics of this patient, and you can believe me, it's you can see this. You can see this patient, the final result in our Instagram. We have published several videos from the final treatment of this patient. Okay. So I showed you the video just to emphasize how fine and sensitive this rolling flap technique is, especially when you're acting on one single implant, okay? The healing after 10 days, then the healing after 1 month. Please note the differences on the vestibular aspect, this critical area for all implantologists. The situation after 2 months, we have here much more gingiva volume than here, okay? We are exactly now comparing the volume of the gingiva on the vestibular aspect. This is an old amalgam tattoo, but it doesn't play a role in quality of the keratinization of the soft tissue. Okay. Then we give the final prosthetics to the patient after almost between 6 to 8 months. After the wearing period of the temporary crowns, we gave each patient the final crown and checked all the patients 12 months after the surgery, meaning 6 months after delivery of the final prosthetics. And this is very impressive. You see, 12 months after the surgery, this is the amount of the keratinized tissue that we achieve using the split rolling flap, and this is the amount that you achieve. Let me say under normal circumstances that every patient and every surgeon is achieving around the world, but we can assume that using the vestibular rolling flap technique, VSRF technique, can improve the final soft tissue status significantly on the vestibular aspect. Okay, now you see here all the statistics. I don't want to bore you to bring so much statistic at the end of my presentation, but just have a look here on the left side. The height was not that much different in both groups. Yeah, the height is not that much different. There is no significant difference in both groups, but in the width we have significant differences using the split rolling flap. Okay, good. Let me summarize the presentation of today. First of all, minimally invasive dentistry is now and future, no matter which discipline. I think every one of you knows how important visual control is in prosthetic treatments like tooth preparations or isolation and cementation procedures. and also composite treatment and all these areas. From today, you know that optical magnification is also crucial in minimally invasive implantology. Secondly, most crucial condition in minimally invasive dentistry, of course, is the visual control and the magnification. Increasing work quality means higher life quality for us dentists, and then also for the patients. Okay, I think everyone will ask me, how could you develop yourself to this level of dentistry work? Okay, I will give you some insights from my life. That is a slide from my TEDx speech that I was preparing for TEDx here in Iran, because so many the Iranian youth, I mean young people in Iran, so many people are following my career, my life, because my life documentary film was published over 100 times in Iranian television, and so many people, they want to know how could you develop yourself and how could you resist in the hard times of your life and make progress. It's very important to know that success is always not happiness, and also the opposite. Happiness doesn't mean that you are successful in your life and you are happy. I think every one of you should think about his career and plan his career according to a happy life. You have to check and see what makes you really happy and satisfies you in your life. It is not always the success and the last micrometer and the last millimeter of your preparation, or what I am doing every day. That is not necessarily, that doesn't go for any of you. Everyone has to check it for himself. I recommend you to keep yourself healthy as much as you can before you go into any plan of specialization, of investment in sophisticated technologies in your clinic, or I don't know, very complicated course programs. First of all, you need to have a plan for your health. I mean, you need to check or to look over your nutrition, your sleep manners, sports, sexuality life, and also happiness. What satisfies you, better than anyone else, what is good for your health. Then try to define vision for your career and goals. I mean, if your goal is to graduate in dentistry and become a general dentist, that's okay, that's fine. If it makes you happy and it satisfies you. I can tell you, and you saw, I finished 3 specialization programs within 10 years. No, let me, 4 years oral surgery, 2 years implantology, 2 years periodontology, and 2 years microdentistry or microscopic dentistry. 10 years specialization. I spent more than 600,000 euros for these specialization programs. I also spent more than 2 million euros for my clinic here in Tehran, where I am doing all this beautiful work, and I am so happy. I cannot wait to wake up every morning to get into my car and come to my office. I can tell you that. But beside that, I sacrifice over 20 years, super hard work every day, and so much stress. But that was the way which made me happy. Otherwise, I wouldn't go for that. So vision costs a lot. Visions and goals cost a lot. Not only your life, but much more investment also. Absolute dedication. Once you have a vision and you have defined the goal, you have to go for it. You have to stick with it. There is no other solution. If you let it go, or you get lazy, I don't know, or you let people tell you, I have so many naysayers around me, still in my family. I divorced one time. I am in second marriage. Even in my second marriage, I have a lot of problems because I have the absolute dedication to my profession. Most of the successful and influential dentistry figures in the world, they don't have happy family lives. I can tell you that because I know them in person. So many of them are my close friends. I know how they are suffering and how they are challenging the family life, or how challenging the family life for them is. So why is it like this? Because they are dedicated to their visions, to their goals. Sacrifice, I mentioned before. Of course, you have to sleep less. Of course, you have to spend everything you have. I can tell you, everyone in my country, Iran, is thinking Shakibaie is buying and is in apartment business, or what do you say? What is خرید و فروش ملک. Real estate. Sorry, yeah, real estate. Most of the rich people in Iran, they are in real estate business. No matter what the mother business of them is, once they have the money, they go into the real estate business because they have the most profit in real estate. And if you ask maybe 100 dentists or 100 people who know and follow my life, they think he must be super rich because he has only 5 patients, and the patients are spending a lot of money in his clinic, and he is certainly spending a lot of money for buying real estate and apartments. But I can tell you, I have no real estate. I am living in a rental apartment where I am very happy. It's a very good apartment. I am super happy with it, but I have no real estate because I think I don't want to spend my money for soil. Yeah, I don't want to spend my money for soil. I want to work with my money. That was the reason why I spent over 2 million euros in 80 square meters in my clinic here in Tehran, because I wanted to have the most sophisticated tools in my hands. That is the aspect which makes me happy. But on the other hand, I have to sacrifice. Why? Because the family is telling me, what are you doing? Everyone has 10 apartments, is buying, selling. What are you doing? You are spending everything for your new developments, for your new equipment, for new articles to write, and so on. So I have so many naysayers around me, and you will have these people around you too. Perseverance, of course. Long life. You have to fight till the last day of your life. Perseverance was very crucial in my life. I think I stick with every goal I define in my life, and this is something I learned from my mother, because my father was very intelligent person, but he had not that much perseverance. That I learned from my mother. Sharing knowledge is my love. I am a teacher. No matter where I go, if you visit our Instagram, you will see we have a lot of films, videos about lifestyle, how people can preserve their health and push their health. Also, we talk about nutrition and everything around health. And this is something which makes me really happy, sharing the knowledge, not only on a specialist level. And of course, you have to keep updated. I spend minimum 3 hours a day beside my clinical treatment work, minimum 3 hours a day to keep myself updated, reading articles, reading books, buying new books, and watching new videos. That inspires me also to go into new areas of dentistry. So only this way I could build up this multidisciplinary concept in my clinic, where we are right now offering actually all the aspects, or covering all the aspects of dentistry, but on the microscope. With some impressions from our last practical course in Istanbul, in cooperation with Carl Zeiss Academy and Turkish Dental Association. I want to finish my lecture today. We will have this kind of courses from next year again. Unfortunately, we had to stop plannings because of COVID. Carl Zeiss Academy stopped organizing courses around the world, but from 2023 we will be back again. Thank you very much. I will be here to answer your questions.
Thank you so much, Doctor, for your interesting presentation. Now we're moving on to the questions part. If anyone have any question, can write it to the chat part.
They will write here, the questions will be written?
Yes, we can see on the screen. Yes. Okay, the first question is you told us the benefits of operating a microscope, but how do you keep the microscope same angle with the patient's head?
Sitting behind the microscope, is a scientific program for itself. It means you work actually either directly or indirectly. In surgery, in the point of surgery, it's very hard to work indirectly with a mirror, But in terms of restorative and prosthodontics, you can learn to work with microscope indirectly using the mirror, okay? And in case of my surgical techniques, you have to move between 9 and 12 o'clock. Okay? While when you are working for restorative and prosthodontics or endo, you can move between 3 and 9 o'clock. According to your position, your assistant has to change the position. When you come to 9 o'clock, the assistant has to go around to 3 o'clock, okay? So working behind the microscope is not a static procedure. You always act dynamically, but it's a full day program, learning to sit correctly behind the microscope and learn the positions from lower and upper jaw. I recommend you to visit courses of Maxime Belograde. Do you know him? Maxime?
No.
Check Maxime Belograde. I write here. This is his name. Maxime Belograd. He is a Ukrainian dentist, restorative specialist. He is one of the best microscopic specialists in the world. I learned a lot from him. He learned a lot from me. We are co-working in framework of Microvision. He is one of the founders of Microvision.
Thank you. And the next question is that
Visit his Instagram. Visit his Instagram.
Sorry. The second question is there any contraindication for sinus lift for patients who have previous chronic sinus issue?
I cannot hear you that good. Can you write me the question, please? Because I cannot hear you good. It was a question about sinus lift. I just understood some question about sinus lift.
Is there any contraindication for sinus lift
Contraindication.
for patients who have previous chronic sinus issue?
Okay. If patients have acute sinusitis, for example, or infection problems, this is absolute contraindication, okay? Acute. It means they have symptoms like swelling, pain, or pus, coming out of nose or in the mouth. This is absolute contraindication. But if they have chronic sinusitis and they are in the rest phase, okay, in the silent phase where they have no symptomatic problems, you can cover the patient and they have no findings inside the sinus, okay, like kystic procedure, I mean findings like a kiss or ranula or rupture, I mean discontinuation of the membrane. If they have nothing like this, no findings in the sinus, and they have a rest phase of chronic sinusitis, you cover the patient with antibiotics for minimum 4 days, 3 to 4 days. They start 1 day before the surgery and continue for 3 days after surgery. You can make the sinus lift.
Thank you, doctor. And could you please compare microscopes and dental loops?
What I prefer?
Compare, yes. What's your prefer and why do you prefer that?
Yeah. Dental loop is a good stage between working with unarmed eyes and a starting microscope. Is a good stage in between because it offers you the possibility to adapt your motoric, the motoric of your hands, your digital feelings of your fingers, and adapt it to your visual control. You will say everybody who is starting to work with the loop will have problems in the first phase, like first weeks. To work in, you have to get the feeling for the dimension, for the distance of working, okay? And that will take some weeks for you to adapt. The problem of the loop is that your magnification power is limited. You have only one magnification factor, like maybe 2, 3, 4, or maybe 5. The strongest loop has 6. You are limited. And you have also the problem that something is sitting on your nose or sitting on your head. This is not nice. That will disturb your nose, your ears, and your head after a while. So there are some limitations for utilization of the loop, but I think it's not bad to start with the loop and then to continue with microscope. Furthermore, you have almost no option for high-end documentation with the loop. There are some small cameras coming out, coming up in the recent 2-3 years with loops where you can film, or make videos, but you cannot make pictures, high quality pictures. And you have always the motion of head, which can disturb the quality of the documentation as well. So there are some big contrasts for the loop if you want to work long term with it. Sooner or later, you will go for a microscope after using the loop.
Thank you so much. Thank you everyone who participated. Although having a complex schedule, we highly appreciate Dr. Shakibaie's time. May this inspire us to go pursue after what we were chosen to do. At the end, I hope we all learned something worthwhile today. Thank you for tuning in and listening. May we have this same occurrence held physically in the near future.
Thank you very much. It was a pleasure.
Bu güzel konuşma için Doktor Behnam Shakibaie'ye tekrardan teşekkür ediyoruz. Etkinliğimize katıldığınız için sizlere de teşekkür ederiz. Bir sonraki DENTALKS etkinliğinde görüşmek üzere. Hoşçakalın.
Thank you.
Teşekkürler, iyi akşamlar.
Eğer ki hayatımızda hiç eğer olmasaydı nasıl olurdu? Size şöyle söyleyeyim. Her şey daha az parlak, daha az yeşil olurdu ve daha az parlak yeşil. Çünkü eğerler ormanların derinliklerinde tek bir kibritle derinlerin kıvılcımını ateşler. Eğerler Nobel ve Guggenheim'ın aklına takılır ve o kodu bu kodu çözerler. Eğerlerle içinizden haykırmak gelir. Eğerler bariyerleri kırarlar. Asla yalnız yürümezler ve aşırı bulaşıcıdırlar. Eğerler aşikardır ve son anda golü atarlar. Eğerler dünü umursamazlar, robotlarla bile konuşabilirler. Karşı takım soluklanırken oynamaya durmadan devam ederler. Sadece basit bir kelime öyle mi? Hayır. Eğerler asla uyumazlar. Hep daha fazla çaba gösterirler. Eğerler bakar, araştırır ve en beklenmedik zamanda ortaya çıkarlar. Eğerler klonlanarak çoğalırlar. Acaba gerçekten yapabilir misin? Yaptın bile. Eğerler aklınıza girmeye çalışan güler yüzlü şakacılardır. Eğerler kapıları açarlar, asla kaybetmeyeceklerini bilirler. Ve biraz gün ışığına her zaman hazırdırlar. Her şey bir eğerle başlar. Çünkü eğerler ne zamana dönüşür, ne zamanlarsa şimdiye. Ve şimdi nasıla dönüşür. Nasılsa asıl. Eğerler bakış açınızı değiştirir. Eğerler oyunu değiştirir. Eğerler dünyayı değiştirir. Biliyoruz. Çünkü biz eğerlerle çalışıyoruz. Yakın Doğu Üniversitesi.